Welcome to the Forgiven Nutritionist podcast. I am your host, Wendy Brinkman, and today I'm going to be talking with Dr. Easton. He started his medical training living in Italy, studying at the University of Bologna Medical School. He then returned home to complete his degree at Rosalind Franklin University of Medicine while doing his clinical training at Cook County Hospital in Chicago. Dr. Easton did his psychiatric residency at Illinois State Psychiatric Institute, and at the time it was the hub for psychiatric research in the Chicagoland area. He was recruited to the Department of Psychiatry at Rush University Medical Center as an assistant professor and was involved in research looking at the treatment of mood and anxiety disorders as well as the treatment of addictions. He's now currently at the Amen Clinics in Chicago, and for the past 5 years he has had a focus on the role of mild traumatic brain injury, infection, toxicity, inflammatory conditions, and their contribution to psychiatric presentations. I think you're really going to like today's episode. Here's a clip.
So you have a lot of people come in with mood disorders. They've had them their whole lives. So a spec scan is going to show me, is there something going on that's diminishing their brain health that's making their symptoms worse than they would be otherwise? What's the most common thing? Head injury, right? And when I say head injury, I don't mean getting knocked out or getting a concussion, which is head injury. I'm talking about mild traumatic brain injury, which most of us have for a myriad of different things, because all you have to do is get your head jarred. And if you've ever looked at the base of your skull, it's got all the, you have an organ that's the consistency of butter or jello in a skull, which is very hard, and on the base has a lot of very sharp edges. So when your head gets jarred, your brain will bang against bone or these sharp edges and get injured.
Hey everyone, just a quick break to show some gratitude to our sponsors and give you some special deals. Are you looking for a good probiotic? Seed DS1 Daily Synbiotic has both prebiotic and probiotic. It supports digestive health, heart health, skin health, and gut health, including those who suffer with IBS. Their products are clinically studied and third-party tested for quality, and I think you'll be impressed with their eco-friendly packaging. Click the link in the show notes and use my code FORGIVEN for 15% off your first month supply. Welcome, Dr. Easton. Thank you so much for being on today.
Well, thank you for having me.
We appreciate you being on. Why don't you give my listeners a little bit of information about yourself and tell us how you got started in psychiatry?
Well, the classic answer why someone gets involved in psychiatry is because they're a little crazy. But I was always very interested in neurology and how the brain functions. And that sort of led me into psychiatry, which I've been doing now for over 30 years. I trained at Illinois State Psychiatric Institute, which is here in Chicago, which unfortunately doesn't exist anymore. It was an exceptional state institution that did research and public service and education. After that, I was there for a couple of years, and then I went to Rush University Medical Center, which is where I was for about 28 years. And traditionally, I was trained as a psychopharmacologist. With certification in addiction. And I did a lot of things over the 30 years there. But throughout the course of my my tenure there, I basically did inpatient and outpatient practice and fundamentally focused on the treatment of more severe mental illnesses and the medical management. And as time went on, I just became more and more interested in alternative treatments to manage people, because traditional psychiatric treatments, although they're very effective, they don't help everyone. And, I needed more tools in my box. So that's how I ended up coming here to the Amen Clinic, where I do a lot more involvement in functional medicine. And also, and we'll talk about this later on, one thing we do here is functional neuroimaging. So we look at the brain and how well it's functioning. So originally I came here with the intent of going into semi-retirement, but it sort of didn't work out that way. So I'm pretty busy.
That's to all of our benefit that you're not retired yet.
Yeah, my patients keep threatening me that I can't retire. So
Well, that's good. That shows that you're well loved and appreciated. So that's wonderful. So today we're going to talk a little bit about bipolar disorder. And over the last couple of years, I've kind of really become familiar or a little more familiar with bipolar disorder. And I think not everybody has quite a good understanding of what it is. Or really any mental health issues for that matter. They just kind of lump sum everything together. So hopefully today you'll be able to answer some pretty good questions.
Hopefully.
Why don't you tell us the differences between bipolar 1 and bipolar 2? Because I know that until, like I said recently, I didn't even realize there were more than one bipolar disorders.
Right. So I'll make it even more complicated for you. There's a large group of illnesses, we call them affective disorders, where the hallmark is people's moods are unstable. Mm-hmm. 20% of those individuals have what we call bipolar disorder, although they're not actually the majority of people. So we'll talk a little bit about, this other large group of people who frequently are misdiagnosed. But bipolar disorder is sort of the more serious end of the spectrum. And what it consists of is people can fluctuate between two very different mood states. Either they can be very high or very depressed. And actually, predominantly, people with bipolar disorder, the vast majority of the time when they're symptomatic, they're depressed. So many of them actually get misdiagnosed as having what we call a unipolar depression, which is a different illness which has different treatments. So bipolar disorder requires that when you're high, you have what we call a manic episode. Mm-hmm. And a manic episode is where people have a period, and the diagnostic criteria is a little different, gets a little technical, but you want to see someone for at least a couple of days where I term it as they're sort of shot out of a cannon. Tons of energy, talk really fast, don't really need to sleep a lot, become very impulsive. They become hypersexual, they'll spend a lot of money, and in the more severe end, they become delusional. And usually it's grandiose. It's either a combination of grandiose delusions or being very paranoid. That's what makes someone bipolar 1. The presence of delusions or psychotic symptoms. So the two most prevalent things would be delusional, believing things that are not true. And then the other one is what we call a formal thought disorder. In other words, from your perspective, somebody would be speaking to you and you're scratching your head going, I have no idea what they're talking about. You're completely confused because what they're saying isn't necessarily logical, doesn't make sense, and they're not a politician, right? That's the caveat. So actually a funny story is when I was a resident and I was at the state hospital, this person comes into the emergency room. And he's very euphoric and animated and speaking a mile a minute, but he keeps telling me he knows Harold Washington, right? Like one of the old mayors of Chicago. And, in seeing him, it's like, yeah, okay, I'm sure you know Harold Washington. We send him upstairs. We have, he was manic. He ends up upstairs on the psychiatric unit. And the next day, the mayor's office calls. So he actually did know Harold Washington. He was the maitre d' at a soul food restaurant that Harold Washington and all his cronies used to go to. So one of the first things I learned is just because people are psychotic, that doesn't mean that some of the things they tell you are not true.
Right.
So now that's bipolar 1. And that tends to be the most serious variant of the illness, in that usually people are going to get hospitalized when they're manic. And then when they're not manic, they will typically go into a very severe depression. So they're challenging to treat because their symptoms are constantly changing, and you frequently have to change the types of treatments that they get. Bipolar 2 is comparable, except they don't get psychotic. So they're still really high energy. They can be very euphoric and or very irritable, very impulsive, speak very rapidly, don't necessarily need to sleep a lot, and can get themselves in a lot of trouble because of their behavior. But again, when they're not that way, they'll tend to cycle into depression. So, a lot of the studies have looked at people with either bipolar 1 or bipolar 2, and about 50-60% of the time they're symptomatic, and the vast majority of the time when they're symptomatic, they're depressed. So the biggest problem is people go to see their doctor when they're depressed, right? You don't go to see a doctor if you're feeling great, you're on top of the world, unless your family drags you in or the police drag you in. So because they go in when they're depressed, a lot of doctors miss the diagnosis and they treat them for depression, which is a completely different type of treatment and typically either is ineffective or makes people worse. So that's bipolar 1 and bipolar 2. And then there's some people who look like they're just depressed and you treat them with an antidepressant and that makes them manic. And we call that bipolar 3, or some people call that bipolar 3. So that sort of encapsulates it. It's a very serious and very disabling illness. People who have it, about 50% of people end up having drug and alcohol problems. Untreated, you have suicide rates that can be as high as 15%. And it typically, chronically, as time goes on, gets worse, and people become less and less functional. So, pretty serious illness. If you look at bipolar 1, bipolar 2, about 2% of the population will suffer from it. But if you look at all mood disorders, people whose moods are unstable, then you're looking at about 5% of the population suffers from that. And they're actually the most common people that come in.
People kind of, like I said earlier, people somewhat, at least the people that I come across, both clients as well as family and friends, they seem to lump people with any kind of mental health condition into just one kind of large bucket. And they don't realize that there's all these different types and symptoms. And especially when someone is manic, I don't know that people necessarily might even recognize what that would look like. A lot of people can recognize more easily, like you said, what depression is because more people go to the doctor when they're depressed. But I would imagine that not as many people go to a doctor when they're manic.
No.
What does the manic or the mania kind of look like?
So basically, I guess the best way to look at it is you look at an individual and you sort of scratch your head and you go, why are they behaving this way? If it's not that severe, a lot of times family members will tell me that the person's just very narcissistic. Because when you're euphoric, you're very self-centered. It's not that they're narcissistic, they're just very self-centered. But what you'll hear is people are just doing things that don't make sense. They end up spending a lot of money when they get in these states, or they end up being very hypersexual and end up having affairs in these states. Or they start investing in a lot of businesses that don't make any sense. I had one patient who he would get manic and he would open up a business and become incredibly successful. And then he would be type 2, he'd be hypomanic. And then he'd go into a very profound depression and his business would fall apart and he'd go bankrupt. And then he'd get manic and he'd build another business. And I'm talking about that he would make millions of dollars and then get depressed and go bankrupt again. Finally, at some point, somebody figured out how to help him keep his money. So he would get manic, create a business, get depressed, his business would, basically fall apart. But, he stayed financially solvent. And fortunately, over time, I got him stable. and he ended up being extremely successful. But it's just, so when medical students come in and we train them, you look at all these diagnostic criteria and you sort of don't understand it until you see it. I mean, that's sort of the problem, because when I say somebody has a lot of energy and they're super happy or they're super irritable, I mean, lots of people can be like that.
Mm-hmm.
So after you've seen this a while, you pretty clearly recognize what's going on. But you're right, for some family members, it's difficult. They just can't figure out why somebody's behaving this way, or why they're so oppositional and they're always so argumentative. It's not that difficult when a family member starts telling you things that absolutely make no sense, right? So if a family member, starts telling you how they have millions of dollars in the bank and Apple, is chasing them because they developed some type of program and Apple's against them, or, the FBI is following them because of certain reasons, things like that, family members know that this stuff just isn't realistic, and they understand there's something wrong. They don't necessarily understand they're manic, but they understand enough to get someone to treatment so they can get help, and hopefully they'll get educated by the clinicians working with them so they can start to understand what the individual's illness is and what they need. But so when somebody's floridly manic, it's not that difficult to understand something's not right. Some people can be not quite that delusional, and they don't necessarily believe things that are really crazy. Mm-hmm. Sort of makes sense, but it's just very uncharacteristic for the individual. So sometimes that becomes a little bit more difficult to figure out. Now, most of these people sooner or later will end up very depressed, and then that's not difficult to figure out. I mean, that is pretty obvious to most people. And that's when, more often than not, they'll end up in treatment. And then, hopefully the psychiatrist will make the right diagnosis and treat them, with the right type of interventions. The people who have unstable moods, they're the ones that are more common and more frequently misdiagnosed. So these are people whose moods, they may not get manic or hypomanic. So they're more difficult to diagnose because they just may be periods where their mood is elevated and their self-esteem is better and they're much more productive. And then they'll go into periods where they're more down and depressed and can't get anything done. And then maybe they'll go into periods where they're more anxious and agitated and restless. And, you can see people flip-flop between these mood states, sometimes within the course of a month, within the course of a week, sometimes within the course of a day. And it's not always recognized that they have actually a psychiatric illness, because they may be functioning, but they just may be very difficult to deal with. So most of these individuals, when they go in to see their doctor, they go in because they don't feel good. So the doctors don't recognize their moods are unstable. And there's a lot of there are a lot of doctors that don't necessarily believe this. Mm-hmm. There are a lot of doctors, and I'm talking about psychiatrists, okay, who believe you're bipolar if you have a manic episode or a hypomanic episode, and you haven't had that, and you complain of depression or anxiety, you either have just depression or an anxiety disorder. And they don't recognize that an individual's mood is highly unstable and they actually have a mood disorder. The difference being, just to make it clear to people who are listening, because it can get a little confusing. So when we say depression, we're talking about something called unipolar depression. And when people have, this unipolar depression, their symptoms are always the same. So they'll be, down, blah, low energy, They could have trouble sleeping or want to sleep a lot. And their thinking typically, as we call depressogenic thinking, they're hopeless, helpless, worthless, overwhelmed, guilty, right? But they're like that every day, all day, day after day, week after week, month after month, right? That's typically unipolar depression. Not always, though, but I'll deal with that in a second. But when people come in and you see that they have these different mood states, so I'll see a lot of people, they'll come in, they'll say, I'm depressed. And my first question is, when's the last day you felt okay? And they go, oh, last week I was fine. How many days were you fine? Oh, 2 days I was fine. That's not unipolar depression, because you don't have days when you're fine. Mm-hmm. Your mood states don't change. It's always the same. So once you see people whose mood states change, you know you're not dealing with unipolar depression. And then people can, flip-flop between being okay, very depressed, very anxious, very agitated. I mean, they can be all over the board. And that can happen rapidly, or you can have people that, get what looks like depression, but it only lasts a week or two, and then they're fine. And then a month later, they have another episode, and then they're fine. And then 2 months later, they have another episode. That also is not unipolar depression, because you don't get multiple episodes in a year. You get an episode, and it can be very long. If you're lucky, it resolves in 3 months, or, you respond to treatment. So this is what's complicated, is most patients come in and they go to the doctor, I'm depressed or I'm anxious. So they get treated for depression or anxiety, and the doctors don't really evaluate the degree to which their moods are changing. And individuals don't know to tell their doctor that, right? Mm-hmm. They just look at their moods as bad. They don't walk in and go, oh, for 3 days I'm down and blah and low energy and I want to sleep all the time. And then all of a sudden I'm like crawling out of my skin and I want to peel my skin off and my mind is racing and I can't sleep. And then I have a day where I'm okay. Actually, I'm great. I whip through the house and clean everything and I do all my shopping because I couldn't function for the past week. Right? They don't ask them that. And the patients don't understand to say that. They just come in and say, I'm depressed. I'm depressed all the time, when actually they're not depressed all the time. So these are sort of the things you see with mood disorders. They're more common than classic bipolar disorder, although the treatments are the same. And all of them, if somebody has bipolar 1 and they've had periods where they're psychotic and they've been hospitalized, few doctors will miss that diagnosis, right? But if they haven't been hospitalized and they have periods where they're sort of hypomanic and it's not clear if it's normal or not normal, and they come in with depression, the diagnosis will get missed. If their moods are highly erratic, the diagnosis will frequently get mixed. And, so why is that important? Well, the treatment for classic unipolar depression is antidepressants. But if you have a mood disorder, antidepressants will potentially not work or make you worse. The treatment for mood disorders are mood stabilizers. So it's a completely different type of treatment. So I've seen people for years who have been treated with the wrong medicines. You put them on the right medicine, and a month later, they're like a new person. In addition to a lot of other things. I mean, it's just, I don't want to make it sound like, medicine is the 100% be-all, end-all to treatment, but it's an important part of it.
I would imagine.
So does this all make sense?
Very much so. And I would imagine that's part of the reason why family members probably really need to be a part, or at least involved at least a little bit. They're probably going to give you, as the psychiatrist or the clinician, some real insights, because sometimes I would imagine that unfortunately the person going through either, whether it's bipolar 1 or 2, or just their unstable moods, they can remember, okay, like you said, being depressed, but they can't remember how long they haven't slept for, or when the last time was they actually did sleep, or how long they've been in the manic state. They just think, oh, I'm always happy, or I'm always on, right, and I'm always thinking. And so
it's the way I describe it is whatever mood state they're in, That's the way they are. That's the way they've always been. That's the way they'll always be. That's how they see it in their head.
Mm-hmm.
And you have to have family members involved. Because family members give you a lot of information. And I've seen people here who will be sitting and they'll tell me that, no, my moods are pretty stable. And you see the spouse or the parent going, no, they're all over the place, right? So family members are important, one, for helping with diagnosis, but even more importantly, these are not illnesses that affect only the person who's ill. Mm-hmm. This affects the whole family, right? It's like having, somebody in the family who has alcoholism. Well, it's not, that person affects the entire family because of their illness. So bipolar disorder is the same. It affects the entire family. So you need to help and work with the families. They, can help give the patient support and keep them on the right track and help them do what needs to be done. Or they can give me feedback that they're not doing what they need to do and they're not doing well. And they also need to get some help themselves to understand what's going on. Mm-hmm. And there are a number of different organizations that exist that can help people. There's NAMI, that's the National Institute of Mental Illness. There's the DBSA, the Depression Bipolar Support Alliance. So these are two organizations created by lay people to help patients and families. So they're not clinicians. Actually, the Depression Bipolar Support Alliance, which is now national, so their chapter is all over, was actually started by patients at Rush many years ago. They were patients of this Dr. Jan Fawcett, who was very well known for treating, mood disorders. And a couple of his patients started this organization to support people with bipolar disorder and depression. And it ended up now, it's an enormous national organization that can offer a lot of assistance and guidance to family members and to patients. So there are those resources. And then, any mental health program usually will have social workers that understand what resources are in the area that can help family members. So, it's not just the patient who suffers with the illness that needs help. It's the whole family that needs help. Now, just to throw a little wrench in that, right? There's a problem in that if you're over 18, a psychiatrist is not obligated to talk to anyone except the patient. Mm. So I can't tell you how many people I see where the parents or family members are just incredibly frustrated because they can't get any information from the doctor because the doctor won't talk to them. And sometimes the patient doesn't want the doctor to talk to them. But it's sort of like a catch-22. I mean, you have to really work with families to help treat people. And families give you phenomenal feedback. I run my practice like if you went to see a family physician. I treat families, right? I'll have, the father sees me, the kid sees me, the grandmother sees me, which is great because they all come in and tell me what's going on with the other person. So I get a lot of information. Now, everybody knows they do that, and it's okay, right? There's nothing going on behind. I'll frequently say, hey, Joe, your dad came in and he said this, and this is going on,
Right.
You have anything to say? You have any thoughts about this?
Yeah, I did have a client, and I knew some other family members as well. And, of course, I said nothing when anybody said anything, but, your patient and your example, my client tells me one thing, but then you hear stories from other people and you're like, okay, I know that, I know the real truth now, which I'm sure is very difficult, especially in your situation, when you're trying to figure out whether somebody is manic or if they just have an unstable mood, or what really is going on, or what's causing some of these issues, or how you can help them if they're not being totally honest, especially early in the diagnosis and early when you first get them. Because I would imagine as time goes on, you build a rapport and everything, but it's hard to get people to open up and be honest and really know things at the beginning.
It depends how you structure an interview with people. So if it's done in a sort of a non-threatening way, and I keep it pretty, and this actually is how you make the diagnosis, I keep it pretty simple, like, let's talk about what symptoms you have. What are your moods like? How do they fluctuate? What different mood states do you have? And I keep it on that level. It's much easier. Excuse me. This cough is never going away. It's much easier for people just to answer those simple questions. Mm-hmm. So, a lot of times it's not really, well, for me, it's not that difficult to have a high level of suspicion of what's going on with an individual, because I've been doing this for 30 years and I've seen thousands of people, right? So when people come in, I pretty quickly get a sense of what's going on with them. Most of the time, not always. There are people who just deny everything. And that's when you really need to check in with family members and see what's actually going on. And sometimes they're right. And sometimes they just really have no insight into what's going on with them. But yeah, it's not that difficult to make a diagnosis if you keep it simple and look for certain things. The way I explain it to people is, and people just don't get this because they think to make these diagnoses, you have to know a lot about the patient and their history and how they react to different things. But you're dealing with an illness with predictable symptoms. Mm-hmm. And so, if you go to your doctor and he listens to your lungs, how long do you think it's going to take him to know that your lungs do not sound right?
Not very long, I would hope.
Right,
yeah.
About 30 seconds. Right? So when people come in, pretty much within the first, well, I get a lot of information when I see people now. So I see their whole history and everything. So I already have a pretty strong suspicion about what's going on with them. But when people come in, you pretty quickly get an understanding of what you think is going on. You spend the rest of the initial evaluation making sure you're right and you didn't miss something. But it's pretty obvious pretty quickly. If somebody tells me their moods are all over the place, if I go, well, do you feel this way for a while, and then this way for a while, and then this way for a while? Do your moods change radically in the course of 2 weeks? And they say yes, there are not too many things that cause that, right? And then the question is there something else going on that's causing these symptoms that make them look like they have a mood disorder, right? And so this is what we do here at the Amen Clinic. This is where spec scans come in, right? Because, just because so to understand, let's start this way, to understand psychiatric diagnoses, basically what's happened over the years is if you have certain types of symptoms, you have certain diagnoses.
Right.
So what people think is if I say you're bipolar, then everybody with bipolar has the same illness. Mm-hmm. But they don't. Right? These are really, you have people who have similar symptoms, but they may have them for very different reasons. My best example is a cough. A cough is a cough. Just because you have a cough doesn't mean you have lung cancer.
Right.
But a cough is a cough, right? So just because somebody comes in with depressed doesn't mean they have unipolar depression. Just because somebody comes in and looks like they're manic, there may be, well, bipolar, if somebody comes in and they look like they're manic, there are not a lot of reasons why that can happen, but you still want to look for those things. Mm-hmm. So what we do here, which you don't really do in traditional psychiatry is start to look at other things that potentially can cause symptoms, say neuropsychiatric symptoms, that look like a particular illness, right? Because psychiatric illnesses are really, you have a cluster of people with similar symptoms, but they have different diseases. That's the trick. So SPECT scans help you tease that apart.
Well, since you brought up the SPECT scan, that's one of the things that I was a little bit floored several years ago when I started really taking control of my own health and really started figuring out and learning about the body and how it works and what it needs to actually work well and work properly, and all the things that I was actually putting in it that I shouldn't have been putting in it and on it, etc. And
you mean like the rest of us?
and when I learned that there was a thing like the SPECT scan, and I heard Dr. Amen talk about, any other doctor you go to see, they're going to literally look at the organ that they're treating, and you have, gas and bloating and it doesn't go away, or your belly's extended. They're going to physically look, they're going to touch it, they're going to look at it, and they're going to order some tests to physically look at it and see what's going on. But the brain is not always one that they look at. So why don't you kind of tell my listeners a little bit about what
is
SPECT
a SPECT scan?
Yeah, exactly. Because it is amazing that you can literally see things in the brain, and it can point you in the correct direction as to how to fix the brain so that the mind then follows. Right. Because it's fantastic.
Right. So there are two things that we're looking for, as you sort of alluded to. Are you doing things that are healthy for you? Mm-hmm. Right. So that's one thing. But the other thing is, are there other things that have nothing to do with what you're doing?
Right.
That have affected the health of your brain, that are either aggravating a genetic predisposition to an illness or causing all these symptoms. So that's what a SPECT scan helps us with. So what it is it's what we call neurofunctional imaging. So a CT, an MRI, a X-ray is a picture of anatomy. That's what you're looking at. It tells you nothing about function. A SPECT scan is where you get a special type of tracer, and what the cameras do is they just measure how well different areas of your brain pick up the tracer. That's all it does. Whether areas pick up too little, average, or too much. In other words, whether areas are over-functioning or under-functioning. And that shows us certain patterns. And we know that when we see certain patterns, they could be caused by a variety of different things that could be causing an individual's symptoms. So there are two areas where, for me, SPECT scans help. The first one is there something going on with a person's brain health that is causing the symptoms we're seeing, or at least in my case, more often than not, aggravating a biological predisposition. So you have a lot of people who come in with mood disorders. They've had them their whole lives. So a SPECT scan is going to show me, is there something going on that's diminishing their brain health, that's making their symptoms worse than they would be otherwise? What's the most common thing? Head injury. Mm-hmm. Right? And when I say head injury, I don't mean getting knocked out or getting a concussion, which is head injury. I'm talking about mild traumatic brain injury, which most of us have for a myriad of different things, because all you have to do is get your head jarred. Mm-hmm. And if you've ever looked at the base of your skull, it's got all the, you have an organ that's the consistency of butter or jello. Mm-hmm. In a skull, which is very hard, and on the base has a lot of very sharp edges. So when your head gets jarred, your brain will bang against bone or these sharp edges and get injured. So like soccer players, right? Professional soccer players, terrible scans from heading the ball. They don't get knocked out. They don't get concussions. They don't even get headaches. But it's this repetitive jarring. So, are you a skier? I bet you fell. You may not have hit your head, but your head got charred. Do you water ski? People go, I've never had a head injury. Do you water ski? Yeah. When you fall on water, when you're water skiing, it's not soft. Right. You get pretty jarred. So there are a lot of people who have done a lot of different sports and a lot of different things. And what we see on their SPEC scans is they have varying degrees of head injury, which is making their illness more difficult to treat. So now, not only you're treating the underlying illness, but you have to do things to maximize the health of their brain, which is where a lot of lifestyle stuff comes in. Mm-hmm. Although that also helps with, psychiatric illnesses. But definitely with brain health, you're now talking about a lot of lifestyle changes people need to make. And then you see some people who've been absolutely fine and they get a head injury and now they look like they have bipolar disorder. But it's all because of the head injury. So this is what SPEC scans will show us. Or, you have someone with a lot of strange symptoms and it just sort of doesn't fit anything. And you look at their brain and the types of symptoms they're having, and their brain looks like they have a lot of areas that are underactive or overactive on the surface of their brain. So they have an inflammatory process. So maybe they have Lyme. Maybe they've been exposed to toxins. Maybe they lived in a water-damaged home, so they have mold. So you see a picture which tells you something's not right, and you know the different things that can cause this problem. And then you look at a person's history, and you figure out what's going on with their brain health that is sometimes causing everything you're seeing, more often than not making their illness more difficult to treat. Another example would be you can treat somebody for depression for 20 years and they do absolutely fine. All of a sudden they hit their late 60s, they become very difficult to treat. And you can't figure out why, right? So another thing SPEC scan will show us, besides head injury and infection and inflammation, or indicate that people have had this, it will also give us pretty good indications whether somebody's developing a dementia. So you'll see people who have done very well and all of a sudden they're not responding to treatment. You look at their scan and it's like, it looks like this individual's developing a dementia, even though they don't have the symptoms yet. Because you can have an abnormal brain scan years before you have noticeable cognitive problems. But once you start getting this deterioration, this neurodegenerative process, you now become more difficult to treat. Because just from the most simplistic perspective, the resilience of your brain has really dropped. So it has a lot more difficulty to cope with abnormalities than it did previously. So these are areas where one aspect of the SPEC scan is helpful. Is there something going on with an individual's brain health that I have to address because it's making them very difficult to treat or causing all their symptoms? The second thing is, can it help in differentiating diagnoses? So you'll have a lot of people come in going, oh, well, I have attention deficit disorder. Now, attention deficit disorder, if you have focus and concentration problems, you'll be told you have attention deficit disorder, right? So again, focus and concentration is like a cough. You can have focus and concentration problems for a lot of different reasons. Mm-hmm. But people go to their doctor, they say, I have focus and concentration problems. They get treated for attention deficit disorder. It doesn't work. It doesn't help their moods. It doesn't make them worse. It makes them worse. I'll look at their scans and they won't have So attention deficit disorder, classic ADHD, is an underfunctioning of the frontal lobe, right? And if you look at SPEC scans, you'll see what look like big holes in the frontal lobe, which holes represent decreased pickup of the tracer. That the brains don't have holes in them.
I was just going to say,
look at these. Yeah, there are no holes.
Hopefully people aren't getting freaked out thinking that they have holes.
I tell them beforehand, I go, this is what a bad scan looks like. By the way, this is not a hole. This just represents that this area is not picking up the tracer well. You wouldn't see stuff like this if you actually looked at the brain. But, I'll see people who their frontal lobes look fine, but their limbic system, deeper areas in their brain, is super, super overactive. So that's actually why they're having all the problems. That's why they can't focus and concentrate. I mean, the best example, so a good way to demonstrate this is there are lots of reasons why people with different illnesses have focus and concentration problems. If you have depression, you have focus and concentration problems. Mm-hmm. You treat the depression, it goes away. If you have bad anxiety, you have focus and concentration problems. If you treat the anxiety, it goes away. If you have forms of bipolar disorder, you're going to have focus and concentration problems. If you treat the overactive limbic system, more often than not, the focus and concentration problems will go away. So spec scans can be, and this becomes much more controversial, by the way, but spec scans, in my opinion, can be very helpful in helping tweeze apart what a person's diagnosis more likely is and isn't. And it's been my impression for many, many years that most people that come to see us, psychiatrists with depression, have mood disorders. They don't have depression. And they come to us because they've had many treatments and they haven't gotten better. And then they would come to my practice when I was down at Rush because we were like the practice you went to if you had a difficult to treat mood disorder. Mm-hmm. So my belief was most of these people had mood disorders, and that's how I treated them. So spec scans have actually supported that belief. So what I see in these individuals is very, very overactive limbic systems. It's just like their brain just lights up in the center core, which you don't typically see in just classic depression or anxiety. So this is what I see more often than not in the people that come to us, because people with just plain unipolar depression, a lot of them get treated by their primary care docs. Mm-hmm. They don't end up coming to us. We see the people who are more difficult to treat. So we're going to see people with true treatment refractory depression. And then we're going to see, in my experience, more often than not, people who are told they have treatment refractory depression, but really they have a mood disorder and they were never treated with the right medicines. So spec scans sort of give me a little insight into what's probably going on. I play a little game before I see people. So I get their spec scans, I get different neuropsych testing that gets done, I get a full history. The first thing I do is look at their spec scans. And based on their spec scan, I go, this is probably what I'm going to see in the history. And, a lot of times I'll look at a scan and I'll go, I'm pretty sure this person's going to have mood instability. And I'll read their history. There's really nothing indicating that, but I'll sit down and talk with them and I find out their moods are highly unstable. They just didn't see it that way. Right. So, they just don't answer the question. So, I found spec scans very helpful more importantly for the individual, so I can show someone and I can go, this is why I think this is a mood disorder. This is what I usually see in mood disorders. This is not what I see with somebody with just plain old depression. We're very visual people, and visual stuff makes a big impact. So the beauty of spec scans is not just for me diagnostically. It's for the patient, and they'll see their scans and they'll go, oh my God, right? Or you'll see a family member look at the scans and they'll go, oh, this is why he acts this way. It's not because he's a bad person.
Right.
It's not because he's trying to give me a hard time. It's because, his frontal lobes aren't working. He's going to be impulsive. Certain area in the front of his brain is overactive. He's going to be argumentative. He's going to be really, or she is going to be really rigid thinking. For some couples, You'll have one person who comes in who has a terrible frontal lobe, so they're bad focus, concentration, executive functioning, very impulsive. And then you have the other partner who has an overactive, what's called anterior cingulate. So they're very rigid and they like things certain ways and they don't like change. So you have these two people who function in the world completely differently. They're always at odds with one another. And when they sit down and you can go, look, this is the way his brain is wired. This is the way her brain is wired. This is why they're this way. Then all of a sudden it's like, oh, okay, they're not doing this to give me a hard time. This is just the way they think about things. This is the way they look at the world. So sometimes spec scans like that can be very useful. So I found them just really, they have a lot of impact with an individual when they look at them. It can be very, very helpful in that, from that perspective.
I'll put a link in the show notes because I know that the Amen Clinics has a page on their website where they have various different spec scans, and they explain what's going on in each one. Right. And I think it might give a little interesting aha moment that people might be able to resonate or think of not just in themselves, but in, family members, like you said as well. It might make them feel a little better too. And I know that, like you said, we're all visual. And yes, we are very visual. And so sometimes, especially when you don't understand why you're feeling a certain way, it does make you feel better knowing that you have an answer. And then maybe, okay, now what's our course of action to help it?
Right. Well, that's what's very helpful. It's like I can go, look, this is, we all come up with all types of explanations why we do what we do. And one of the more difficult things I do is, people want to tell me all those reasons. And I have to apologize for interrupting them and going, let's just talk about what is, not why you think it is. Because what happens is there's some very interesting studies that were done in the old days, people with intractable epilepsy. They would cut the corpus callosum. That's the area that links the two sides of your brain together, right? So the left and right brain couldn't communicate to one another. And then, I'm not going to bore you with the details of how they did this, but they would give the left brain an instruction and have it do something. And then they would have the right brain look at what was done and tell them why was that done. And your right brain will come up with every explanation in the world, none of which are right, as to why it's seeing what's happening. So this is what I see in people. Our right brains are reason generators. We have to come up with reasons why we do what we do. And sometimes it's very helpful to tell somebody, no, this happens because you have this weak circuit and it causes your moods to get unstable. And that's it. It's as simple as that. We just need to figure out how to make your circuit stronger and give you the tools to learn how to deal with all of these issues. And then, of course, also where things like psychotherapy come in is, people have suffered a lot of consequences because of their illnesses. Mm-hmm. So therapy doesn't only help you learn how to manage your symptoms and recognize them. It's also going to help you deal with all the psychological baggage you have because of the illness you've had for so many years and all the things that you've done, and just goes on and on and on. So
recently I started running the OAT test, which is an organic acids test for people that don't know what that is, to see any possible deficiencies in key nutrients like vitamins and minerals and coenzymes. And it also helps you with figure out a little bit about how their neurotransmitters are working as well. And and I know that when I look back in my history, again, I never got tested for anything when I was growing up, but I know that vitamin B, for example, can play a big role in moods and how your body functions well. But so that's one of the things I wish I could go back and do is test myself too, to see what was possibly going on, or was it just a gluten sensitivity, or, or was there something else going on? But what kind of role does nutrition play in your treatment approach when people are diagnosed with bipolar or any of the mood disorders? Are there foods that you totally tell them to stay away from, at least for the beginning, while they're trying to work on mending themselves? And are there foods and drinks that you maybe want them to for sure incorporate, again, at least at the beginning, to help their brain?
So I was thinking about what's the answer to this question, because this is in part about nutrition. First, as far as testing, so there are some people where the problem is fundamentally they have a severe nutritional deficiencies, right? So what are the things that can be going on that are affecting an individual's brain health that are either causing or aggravating their condition? And, vitamins, minerals, amino acids, fish oil, omega-3s, all the stuff we need for our cells to function optimally. And we all have deficiencies. And we all have certain areas where we have holes. And some of those deficiencies, if you correct them, can make a big, big difference in people. It may not solve the problem,
right,
but it decreases the intensity of the problem. So there's a lot of value in doing that, even more so when people are having cognitive problems. As far as what food should a person eat or not eat if they have a psychiatric illness? Don't eat crap. I mean, there are a lot of perspectives about certain foods are good for certain things. Actually, if you really want to look at foods affecting mood and well-being, traditional Chinese medicine has done the best at this, because they have 5,000 years of an observational science in what types of foods can be used for different things. And if you know anything about traditional Chinese medicine, or if the viewers know anything about it, it can be very elaborate. Also very complicated to do. So, I think the more important thing for people is eat healthy. Don't keep putting things in your body that are going to make your brain work less, such as don't eat tons of sugar. Don't have a diet that's, based in very high carbohydrate, diet. The best diet for people, I think, is a Mediterranean diet. That's what's going to help the most. There's some people who, I've seen cases where a ketogenic diet has really made a major difference in their life, but these are unique situations. And I wouldn't say that if you're bipolar, a ketogenic diet is the answer, but for some people it ends up being the answer. I think it's moderation, healthy eating, no drugs, no alcohol. This is all common sense stuff. Right? Because when you think about it, most of the people that you see, more likely than not, don't have great diets.
Yeah.
Right.
And unfortunately, especially since you mentioned alcohol, they think it gives them a sense of calm, or they think it helps relax them, but it ends up really putting their brain on fire. And just because they can't see it, literally, unless they have a Spect scan, it really does. It can cause other effects, especially if you already have some kind of inflammation going on, especially in your brain. It definitely does not serve you or your body or brain well.
Alcohol is what I call an equal opportunity toxin. Whatever your weak link is, that's what it's going to affect. So it's your weak link, your genetic predisposition. Like, you don't get not everybody will get cirrhosis of the liver if they're a heavy drinker. You have to have a genetic predisposition for that. So some people it's the liver, some people it's blood pressure, some people it's cardiovascular system, other people it's their brain. So if you have a mood disorder or psychiatric illness, your brain is the weak link. So alcohol and drugs are going to aggravate that. And the problem is that when you're under the influence, you may feel better. But the problem is in the big picture, it makes your illness worse. So it actually can aggravate a lot of the symptoms between use. Right. So, if you're like a binge drinker and drink heavy, on Saturday nights, that can disrupt your brain chemistry for the rest of the week. And then you go and do it again the next weekend. Right. Same thing with cannabis. Cannabis is interesting because cannabis can do one of three things. I've seen people where nothing works and the only thing that diminishes their anxiety is cannabis. I've tried everything. What are you going to do? If that's the thing that works, it really becomes the lesser of evils. But for a lot of people, what happens is it will either decrease their symptoms, so you don't really know what you're treating. It will aggravate their symptoms, so they get a lot better when they stop. And then for some people, it doesn't do anything, although it diminishes their brain health over time. So, cannabis, alcohol, although it may seem like when you're under the influence, it's helping you, it fundamentally makes the problem worse over time. And I haven't seen too many people who stopped drinking and stopped, using cannabis that came in and go, oh, I feel so much worse. I would say 95% of the time people come in and it's like, I feel so much better. But they still will go back and relapse because they have an addiction. And that's part of addictions.
Yeah.
And, so that's a whole other dimension of treating individuals with these illnesses is, how do you get them to stop using and stay stopped, which sometimes is not always so easy.
Since you brought up cannabis, I've seen, again, on the website and in your office, what some spec scans can look like from taking marijuana. So maybe you could tell the listeners too what that actually does as well. I personally don't recommend it and I don't use it. I don't suggest it. And especially once I saw the spec scans, I would think it does not serve the body. So maybe you could kind of tell them what you see when you see it on a spec scan.
Yeah. So when you see a spec scan, for somebody who's a heavy, and I have to differentiate this, a heavy cannabis user, chronically over long periods of time, their brain looks terrible. It looks like a sponge, with tons of little holes in it. Cannabis is not brain healthy. There's just, and to think any other way is, we're just kidding ourselves. Now, does cannabis have some valid medical applications in certain situations? It's possible. We still have to learn a lot more about it. But again, then, you're dealing with certain situations where it's the lesser of two evils. Which is worse, the disease or the effects of cannabis chronically, right? If a disease has a 15 to 20% probability of you suiciding every year, but cannabis will keep you well, but maybe you'll have problems 20 or 30 years later because of the effect on your brain health, it's pretty obvious what the choice is. And these are always the choices in treating people because everything, even supplements, have potential side effects. So the question is are the side effects way, way less than the disease? So there probably are some valid reasons to use cannabis, not as many as people tout. And in the big picture, it's just for the vast majority of people, it's not. Dr. Amen, uses the phrase. I don't use a lot of his phrases, but this one I like. when you do something, does it love your brain?
Yeah.
And if it doesn't love your brain, don't do it.
Right.
And cannabis does not love your brain. And, there is no, when people who are using cannabis for different things, it's not like they're going to physicians or practitioners and there's a lot of research and it's well established and they know what does what. They listen to their friends, they read stuff on the internet, which everything on the internet is true. So that's probably a good way to get information. Or they go into a dispensary and they have these people in the dispensary tell them what they should use for what problems, who have no medical education at all. And they're just saying what they've heard other people say. So, it's just not in your best interest. Just like alcohol is not in your best interest. As I tell people, everything in life is about moderation. If you're well, is it okay to have a few drinks every once in a while? Sure. Although there's research that says even if you have a drink a week, that will shorten your life expectancy.
Right.
Right. So it's all about moderation. But if you have an illness, which cannabis potentially can make worse, you don't want to be using cannabis. And that pretty much goes for all psychiatric illnesses.
Yeah, I'm glad to hear you say that because, like I said, once I physically saw some of those SPECT scans, it was mind-boggling to me, like why anybody would want, especially if that were my brain, and it's not even my brain, and I fell in love with it and was passionate about it. It's like I can't imagine. I know how difficult life is already, and then to want to put something in my body that I know for sure is going to harm my brain, which is the most important critical part of my body probably. Yeah, I couldn't do it. And I definitely am hoping that my clients don't want to do it too. So
it's not in your best interest. I mean, maybe you go to a Grateful Dead concert once a year and smoke a joint. Okay, I can deal with that.
Right.
But, any regular use of cannabis, it's not, it's just bad for you.
That kind of fits with my next question, which is lifestyle modifications, because some people consider that a regular part of their lifestyle. But what other kind of lifestyle modifications, especially when they have bipolar, whether it be 1 or 2 or any mood disorders, do you recommend or suggest?
It's the same thing. I mean, it's really no different than I would recommend to anyone else. Exercise.
Yes.
Eat well. Get adequate sleep. Learn how to manage your stress. These are all, lifestyle changes that we all need to do to maximize our lives. And this is what you need to do when you have psychiatric disorders. Now, the problem is a lot of these disorders rob you of your motivation to do these things.
Yeah.
So it becomes difficult. So sometimes you have to get people well enough so they're able to start doing these things and make these changes in their life for the long term. But it's not anything, it's all common sense stuff. Mm-hmm. Eat well, don't eat a lot of crap, get sugar out of your diet, don't live on processed foods, don't drink sugar drinks, don't do drugs and alcohol, exercise, and it doesn't have to be, it could be moderate exercise. It does, what I tell people is, like, brain healthy exercise can be as little as you walk on a treadmill 30 minutes 4 times a week, increase and decrease the incline. That is brain healthy exercise. You don't have to go to CrossFit and kill yourself.
Right.
Right. I mean, if you want to and you're young, that's fine. Weightlifting actually is the best exercise in general. But, and then if you want to go a little further, things like meditation, different ways to manage stress in your life. These are all the things I recommend to people. It's not complicated, and it's not anything that I wouldn't recommend for anyone, even if they're healthy and they're not doing it, because sooner or later they won't be healthy.
And I'm glad that you mentioned the exercise, and I'm glad that you also mentioned that it does rob you of the motivation. I do remember because I had suffered with depression and anxiety for close to 50 years of my life, the first 50 years. And I do remember like never feeling like doing anything. And I remember I literally had to force myself, even if it was just to go to the grocery store, but I had to force myself. And every day I tried to force myself to do something else or to go hang out with people, just because I knew that the worst end would be me just sitting at home, not doing anything. And the spiral would get worse. So even if you don't feel like going to the gym, which I still to this day don't feel like doing, and I still do it.
Well, that's why I have a gym in my house, so I don't have to go to a gym. And there's some people who can, that's the big question is why is it some people can, as miserable as they feel, they can push themselves to do these things. And then there are other people who are actually maybe even less symptomatic, but they can't push themselves to do things. It's I don't know what the answer to that is, but it's a very humbling experience trying to get people to motivate themselves to do things. But yeah, you're right. When you have these disorders, you have to push yourself to do stuff, which then sort of gets a life of its own. Mm-hmm. Right? It's all about, providing structure. Having structure in your life, finding things to get you out of your head. Because if you're not doing things and you're in your head, your head will just make you worse. Because, you'll just have all these negative thoughts roaming around up there that sometimes you just need to distract yourself. And what you see with a lot of people who are really, really severe, that's a separate issue. But most people, what they'll tell me is, if I'm doing things, if I'm active, I feel okay. So when I'm not doing things, that it's a problem.
Mm-hmm. Yeah, I remember that feeling too. But for me, it was, I had to hit what I call a bottom. And when I saw that bottom, I did not want, and my bottom was still at the shallow end of the pool. I knew that pool could only get deeper. Right. And I saw what the deep end of the pool could look like. And I just tried like heck to stay at that shallow end of the pool, because that was not a good experience. Right. So yeah.
I think everybody has a different threshold of where they get to a point. It's like, I can't, I got to do something. I'm not going any further down.
Well, that's good. I think you've given some people a lot of good things to kind of think about. But one thing I like to get my guests to suggest to my clients is, or tell them, don't miss this moment. If you could have my listeners not miss one thing, what would it be that you would want them to take away from the conversation today?
I have to think about that one. What would be the one thing?
It could be two things or a general thing. Right, it doesn't have to be specific.
Well, first, if you do have problems, make sure you find yourself a competent, good clinician to go and see. Mm-hmm. And don't be afraid to look at what's going on, and don't minimize things away. Do things to take care of yourself. That's the biggest obstacle to people, is they just sort of minimize what's going on and they rationalize it away as normal, as opposed to looking in it and go, okay, something's not right here. I need to get some help.
Which can be very difficult. And I think that to me is the biggest, best thing that you can do for yourself and anyone around you, of course, but especially when you do something for yourself like that. Yeah, it's the best piece of advice and the best thing you can do for yourself. Yes, I completely agree. Because
I can think of a million different things that you could do, but if you don't do those things first, you're not going to do all those other things. Because if you don't recognize that something, you don't fix something if you don't think it's a problem. Mm-hmm. So, you have to be honest with yourself and recognize what's going on.
And one thing I learned too is it's okay to ask for help. So that's okay.
Right. Yeah. And for family members, be compassionate, right?
Yeah.
Remember, a lot of people, these are illnesses. They're not doing all this on purpose. You have to be compassionate, and then people might be more willing to listen to you. But if you're angry at them, that makes it way more difficult, And that's from the Dalai Lama. The Dalai Lama says compassion.
Words to live by, though, that's for sure.
That's right. You have to have compassion.
And I definitely appreciate you being on today and taking time out of your schedule and evening to talk with me.
More than happy to come back and ramble on about other things in psychiatry.
Well, I will definitely take you up on that.
All right.
I will gladly have you on another episode to talk about any brain injuries, traumatic brain injuries.
More than happy to come back.
Thank you. Pendulum Probiotics is a powerhouse in gut wellness. Akkermansia, Metabolic Daily, and Glucose Control all contain Akkermansia, which is a key player in gut health. It fosters the growth of Akkermansia, aiding in digestion, nutrient absorption, immune resilience, and a positive impact in your overall well-being. If you're ready to experience Pendulum Probiotics, unlock an exclusive 20% discount on your first month's membership by entering my unique code when you click on the Linktree link in the show notes. If you want to continue learning and hearing all things nutrition for your mind, body, and spirit, click like, subscribe, or favorite me on whatever podcast platform you use. Or you can find me at ForgivenNutritionist.com. This podcast was designed to educate, inspire, and empower you to achieve your health and wellness goals with your current healthcare provider. It is not meant to diagnose or treat any illness or medical condition or take the place of any treatments from your current healthcare providers.